Hello, everyone. Happy Friday. It's so nice to see all of you bright and early in San Francisco, but maybe in the middle of your day or after an afternoon nap. Thank you for making the time to join us. It's always a thrill. We have today in the case presenter seat somebody who, if you don't know yet, you will become very familiar with if you spend the next 2 weeks on VMR because Zach, who is an R3 at Emory, is presenting not one, not two, but three cases in the span of 10 days, less than 10 days. I will pass the mic to you to say hi. Tell us a little bit about yourself, although VMR is not new to you, of course, but maybe some of the folks who've joined recently.
Yeah, hey everybody. I'm Zach Owens. Like Robbie said, I'm a PGY3 at Emory. Have like a strong interest in clinical reasoning, pulmonary and critical care medicine, and general internal medicine. So I'm happy to be here to present this case to you.
And Zach, I know I have a little bit of inside information on some big events happening in your life, but I don't know how much of that are you willing to share to the general VMR crowd.
Oh yeah, we can share whatever.
You have a big event coming in the next month or so. Tell us more outside of medicine.
Oh yeah, for sure. I got married like 6 weeks ago, and we're planning an extended honeymoon after residency graduation to go kind of tour around Europe for 6 weeks. So super excited for that.
It's like Zach is giving all the details probably for time's sake, but you would be very jealous of his itinerary. And I was 6 whole weeks of just pure fun. Well, we're really excited to have you here, Zach. Prof Rez has popped up on my screen. Hello, Prof Rez.
Hello, everyone. Oh, hi, everyone. For some reason, my desktop didn't log me onto Zoom, which I don't know if that's like a signal to a difficult discussion that's about to unfold, but we're here now, Robbie.
Amazing. Yeah, it's a little sad that we can't see the Batman and Superman inspiration behind you today, but I think
Listen, you're the only Batman I need.
let the flirtation begin. We haven't even started the case yet. All righty. Well, Zach, we're ready whenever you are. And I feel Prof Rez has got his coffee for the first aliquot, I think.
Nice.
Zach, I
Yeah,
hope
yeah.
you're going to bring it today, man.
Yeah. Yeah, I'm excited to hear y'all's thoughts on the case. Cool. Well, I'll go ahead and get started. So the chief complaint is altered mental status. And the initial HPI starts off as a 53-year-old male who has a bilateral lung transplant from 10 years ago, who's presenting for 3 days of confusion and abnormal behaviors.
Amazing. Can you grab me some sunflower butter?
Oh, Zach, is this the first pause?
Yes, yeah, sorry. I'll let you guys know when I'm done with each aliquot.
No, totally. I'm actually really excited to discuss this. And the reason I am, Zach, is because I'm not at a primary transplant center. So I don't often see patients who have transplants. And therefore, it's going to be a gap in my knowledge. And I'm going to be very cautious to how I approach it. And I'm more so excited because after this case, I'll be reflecting on it and creating a framework for approaching such cases in the future. Because without a doubt, I do admit some patients who have transplants, but it's really not the majority of my work, like you would see at a coronary care center where it's a primary transplant institution. In fact, I graduated from Pitt Medical School where the first successful liver transplant happened by Thomas Starzl. They named a building after him. And I just want to mention one more thing, that this morning we admitted a patient who presented with right upper quadrant pain. And this is a question for the audience. Had right upper quadrant pain for a couple weeks, had thickening of the gallbladder without cholecystitis. Surgery was consulted, a CT was obtained, but ultimately was diagnosed with heart failure. What is the cause of right upper quadrant pain that causes gallbladder wall thickening and chat and someone with heart failure? We're gonna table that. But here's my approach. So we have an approach to altered mental status. And I would say you should take the same approach to a patient who has had a transplant because common things are always common. And when you're approaching altered mental status, it's good to put a tempo on it. The tempo is going to help you significantly because if someone becomes altered hyperacutely, then you're worried either about a sudden neurovascular event, a seizure, or a toxic metabolic event. But most of the times in internal medicine, when we're dealing with a patient with altered mental status, it's more on this tempo, the acute tempo. And when you're in the acute tempo, all that stuff like toxic metabolic, so like reviewing the med list to see if there's any culprit medication, looking at the CMP, the sodium, the glucose, the calcium, even the phosphate, and very rarely the ammonia. Like I mean, this is more CPC presentation, but hyperammonemia. I was in Japan where Jack Penner was, and we had a patient with hyperammonemia induced altered mental status from a Klebsiella or Proteus UTI. The point I'm making is when you're approaching this altered mental status, think toxic metabolic, think, can it be infectious? Can there be a structural etiology in the brain? Could there be seizure? Then we have to incorporate this past medical history of transplant, because that past medical history, and I'm going to create this framework in real time. Can this altered mental status be a complication of a medication that the patient is on, either direct toxicity or because it's caused immunosuppression, making them vulnerable to malignancies or infections? So a medication side effect, direct or a consequence of that medication. Can it be a resurgence of the disease that led to pulmonary failure? Here it was IPF. IPF is isolated to the lung, so it's probably not that being the issue. And can it be a dysfunction with the organ that was transplanted? Here being the lung. Could there be hypoxemia? Could there be difficulty breathing that's tipping this patient over? And the last thing to consider is, like, you've literally transplanted someone else's graft into this patient, and graft versus host disease. But graft versus host disease usually leaves its signature on the skin, the GI tract, and yeah, the mucosal surface and the external surfaces. So I would love to hear if Robbie has any additional thoughts, but I think with altered mental status, the tempo is queen. The medical causes are the mismnemonic, but don't forget about like structural and seizure. Here with the history of transplant, think, can it be a direct toxicity of the med? Can it be a consequence of immunosuppression from the med? Can it be a failure of the organ that was transplanted? Or could there be graft versus host disease that's leading to the altered mental status? Robbie, you're on, man.
I have nothing to add. I just have one major life update to share with you all, since we're diving deep into this case, which is my life started with yogurt, and then it moved to oatmeal, and now it has moved to acai bowls. So if you see purple stains on my fingers and my mouth, worry not. It's healthy, nutritious stains. That's all I have to add, Prof. Rez. All right, Zach, mic to you.
Dude, soon they're
Yeah.
going to be solving our altered mental status.
Yeah, great discussion so far. So the next aliquot will take you through the remainder of the HPI. So I'm going to go back about a month prior to this presentation. This patient was hospitalized at a neighboring hospital for fevers and dyspnea, and was found to have a right middle lobe cavitary lesion on his chest CT, and was ultimately diagnosed with nocardia, Yersinia pneumonia, and bacteremia. And he was started on Bactrim and then discharged home. He was doing relatively well up until 3 days before he presented, when he started having nonsensical responses to questions, and he was repeating himself over and over again. And so family brought him to the ER for evaluation of these new symptoms. And I'll pause there.
That's super helpful context, Zach. And I'll just kind of reflect big picture because there's very helpful information, but it's not that much, and see what else Prof. Rez has to add. We found that Prof. Rez's schema about altered mental status and transplant complications bore fruit for the last month since he had an immunocompromising related infection. That's namely nocardia. Nocardia is a soil-borne organism that's found worldwide that has a propensity to invade either the lungs or the skin, depending on the kind of organism. And in those patients can cause subacute diseases, either of the skin or the lungs. And here it seems to have affected the skin. No matter where the nocardia begins, it has a strong propensity towards the brain, which is relevant for our subsequent conversation. And that conversation is really understanding what exactly the patient means by altered mental status. Most of the time, when we, as internal medicine people, say the words altered mental status, what we're talking about is a change in the level of arousal. Is the patient more or less sleepy or more or less agitated? This change in behavior and communication may be labeled as a diffuse global encephalopathy, but a more precise label may be that this person has focal cortical dysfunction related to language, hearing, or processing. So for me, I'd be really interested in highlighting in red what exactly the family said his, quote, altered mental status was. Because the question will be, should we keep those words as precise as possible? And do they map onto a precise cortical region? Or should we translate those words into altered mental status to reflect global cortical dysfunction? And I think what the family says is helpful, but what we observe too on our exam is the patient globally encephalopathic, or is he focally perturbed in some way, shape, or form, will help us figure out what our problem is. And I think that's going to be something really important to track. Anything to add, Prof. Rez?
Nada.
All right, Zach, tell us more, please.
All right, great. So the next aliquot is going to go from past medical history through allergies. So first, medical history, he has pulmonary fibrosis secondary to sarcoidosis, and he had a bilateral lung transplant 10 years ago. He has end-stage renal disease related to calcineurin inhibitor-induced nephrotoxicity and is on dialysis. Also has a history of pulmonary TB that was diagnosed 30 years ago, and he did receive treatment for that. He has hypertension and diabetes. For his medications, he is on tacrolimus, mycophenolate, prednisone 5 milligrams, Bactrim Monday, Wednesday, Friday, and labetalol and amlodipine. And then from a family history standpoint, he has no relevant past family history. Social history, he lives lives with his family in southern Georgia, and is currently on disability and not working. In terms of health-related behaviors, he has no tobacco, alcohol, or substance use, and then no recent travel or other high-risk behaviors. I'll pause there.
This is a rich aliquot of information, Zach, and it just tells you how complicated medicine can be. And I say that because just look at that past medical history. I was mistaken. I thought he had idiopathic pulmonary fibrosis, but it seems like he had fibrosis from sarcoidosis. And there are a few diagnoses in medicine, probably many diagnoses in medicine. Wherever you see them, you should just question as to how people arrive at the diagnosis. And one of those situations is sarcoid. Usually with sarcoid, it's a diagnosis of exclusion. You have granulomas, primarily involving the lungs, but it can really have a lot of extra pulmonary manifestations, really affect any organ you can imagine. Just think of it as like a granulomatous disease, and you have to rule out infections and cancers, but sometimes you miss those infections or cancers. But in this case, I would highly doubt that they missed it because they literally removed the lung, and I'm sure they analyzed the lung. So I doubt that they missed it, and I think sarcoid is the correct diagnosis. The question becomes, so what happens? You treated the lung by transplanting it, but sarcoid is such a diagnosis that we don't understand. Like, we don't even know to put it in the autoimmune bucket. the immune dysregulation bucket. We just don't know what drives sarcoid. So could this patient's sarcoid be resurging? Now, cavitary lung lesion and sarcoid, that doesn't hit. That doesn't hit for me, to be honest. But we have to be open to the possibility of recurrence of the sarcoid. And then another mistake that you can easily make here is try to blame one etiology for the patient's confusion. It can be multifactorial, and each of those can be contributing differently to his encephalopathy. And in this case, looking at the medications, like some of these medications are just well known for their neurotoxicity, like tacrolimus. Usually a clue is that there's a tremor, but I'm open to the possibility of it manifesting in any shape, way, or form. So ultimately, all this aliquot of information does for me, it says, hey, this patient's immunocompromised, is vulnerable to infections, has a history of sarcoidosis, and is on medications with direct neurotoxic effects. So how do we make progress? We go to the physical exam and we hope that there's something like a myoclonus, a tremor that may prioritize one over the other, but we don't close the door. We keep our DDX broad, and when we go to our labs and imaging, this is a patient where you're more aggressive in the workup, as opposed to someone that has a healthy past medical history or has dementia, has some urinary retention. You don't need to go crazy with your workup. But in this case, the diagnostic threshold is much lower than in other cases. Robbie, what else would you add here, my friend?
Oh, there's nothing left to add, my friend. That was superb. I love the point that the net we're gonna have to cast is pretty wide here, and I'm excited for Zach to begin to share them.
Yeah, sounds good. So I'll walk you guys through his physical exam. Start with his vitals. Temperature was 98.5 Fahrenheit. Heart rate was 80. BP was 121/73. Respiratory rate was 14. And O2 sat was 95% on 2 liters of nasal cannula. For his physical exam, he was resting comfortably, no acute distress. His HEENT and cardiac and abdominal exams and his pulmonary exams were all normal. But his neuro exam, he was alert and disoriented. He was unable to repeat months backwards. He was mixing up his left and right, and he had difficulty with abstraction. Also had impaired heel to shin testing bilaterally, and was bradykinetic on finger tapping with a low amplitude postural tremor. And otherwise, his cranial nerves were normal, his strength was normal, and sensation and reflexes were all normal. And he didn't have any skin lesions or joint problems.
This is super helpful, Zach. I think it's really cool to reflect on the first episode of the CP Solvers being about acute altered mental status. And if that episode is familiar to you, or our subsequent 1 bajillion trillion conversations about it on VMR, you'll remember that the approach we use is called MIST, M-I-S-T. As Reza already alluded to, M is metabolic, I is infection, S is structural, and T is toxin. And I want to share with you a concept that lies underneath that approach. That concept is to try to understand altered mental status as a primary brain problem, or as the brain being the victim of a systemic disease. When the brain is a victim of a systemic disease, it tends to be affected in its whole, rather than in focal, discrete ways. That's not always true. Patients with hypoglycemia can have a focal seizure. Patients with infections can seize from their underlying structural disease in their brain, excuse me. But in general, whenever you find focality, the odds are the problem is in the brain. And when there is no focality, the odds are outside the brain. But of course, odds are just odds. They don't define what's happening. Here, the very astute, precise neurological exam demonstrate a tremendous amount of focality in language, in motor coordination, specifically with signals towards the basal ganglia with bradykinesia and a postural and a low amplitude tremor, and with signals to the left temporal region with his impaired repetition, a frontotemporal region with his impaired repetition. What does this mean? This takes Reza's advice to dive deep into this case and pushes us to not be satisfied with simple intracranial imaging, but rather to dive deep, probably with an MRI with and without contrast. That does not obviate us from doing a very thorough systemic workup because the brain, the focality in the brain may have been subclinical and brought to light by a systemic process that lowered its threshold for detection, or more commonly, that the brain is part of a systemic metastatic disease process as simple as sarcoid or as morbid as nocardia in the lung and the brain. So I think for me, I take this exam and I say, I got to understand everything about this person's whole body, and I got to understand his brain in rich detail, the richest detail I know, an MRI with and without contrast. The one piece of practical advice I will share with you is to divorce the notion of a creatinine from contrast. The contrast-induced nephropathy is a controversial conversation with regards to iodinated contrast. The risk of contrast complications from gadolinium, the contrast agent used in MRI, is now essentially zero. Historically, there was a risk of nephrogenic systemic fibrosis, but this risk is no longer applicable to modern ferric-based contrast agents for GAD. So I wouldn't need to wait for the creatinine to order the MRI with and without. I would probably order it right then and there. Practically speaking, I'd be most worried about the patient's ability to tolerate and participate in an MRI, and their ability to lie silently flat and not move may be limited by their disorientation. That would be a logistical problem that I think falls upon us not infrequently. Any other thoughts, Prof. Rez? Anything else catch your eye?
I love that. The only other thing that caught my eye was this impaired heel to shin testing, which I know is difficult to do if someone is encephalopathic. And it just prompted me to think, could the tremor be a cerebellar tremor? And is there an issue with the cerebellum? But I agree with you. It seems like even if we find something in the brain, it's multifocal. So it's going to be really interesting to see that MRI, but I'm leaning on the side of it being image positive rather than image negative, despite multiple neurologic findings. So I'm looking for like a multifocal lesions within the brain.
That was a really good pickup. I completely agree with you. I'm analyzing the exam differently now. Thank you, Prof. Rez.
Right, great discussion. So yeah, I'm gonna walk you guys through some of the labs that we got initially. So his white blood cell count was 4.9, which had improved from 25 at the neighboring hospital when he was admitted for pneumonia. His hemoglobin was 7 with an MCV of 99, and that was chronic. Platelets were 148. Sodium was 133. Potassium was 3.6. Chloride was 93. Bicarb was 27. BUN was 57, and creatinine 8.1. Glucose was 82. Calcium was 7.7. Magnesium was 1.9. AST, ALT, alk phos were all normal. Albumin was 3 and total protein was 5.2. And I'll walk through some of the other initial labs we got. So TSH was normal. His HIV antigen antibody test was negative. We had repeat blood cultures that had documented clearance of the prior nocardia bloodstream infection. And we had a negative serum cryptoantigen, beta-D-glucan, galactomannan, toxo IgG, and a negative EBV DNA PCR from his serum. Yeah, I'll pause there.
Wow. And can you, Zach, remind me, by the way, Zach, you look so much like one of my colleagues. I'm going to take a picture of your face and send it. I think you're his doppelganger. Look him. Well, I don't want to distract the audience, so I'm not going to say his name. But can you remind me, is this patient on dialysis or not?
He is on dialysis.
He is on dialysis. Okay,
Yeah.
got it. No, that's really helpful. Yeah, so I think Robbie guided us extremely well. What we're doing with these labs is to see if we have a hit that may explain this patient's encephalopathy. but his encephalopathy just seems like multiple focal neurologic dysfunction. So it doesn't sway me away from doing an MRI of the brain with gadolinium. I really have nothing to add on the CBC. It seems like this is his baseline. So I wouldn't really invest much cognitive effort beyond noting it's there and knowing that it's probably in part related to his end-stage renal disease, in part related to inflammation and such. Then looking at his Chem7, I was a little surprised by his bicarb of 27 because he does have end-stage renal disease. I don't see that he's on bicarb. Usually those patients run a little low. But again, I'm not investing too much time in that and saying, oh, is there a reason for an alkalosis? I think with these tests, you got to be cautious, okay? And I say you got to be cautious because when someone is immunocompromised, they don't have the best ability to make antibodies. And so serologic tests may not be as accurate in people whose immune system isn't intact. I can't tell you exactly how inaccurate or how low the yield might be because of the meds this guy's on or the transplant he's received, but I know enough to be cautious there. And then when you're sending fungal antigens, it's important to know that, and I'll just do a quick like 10-second teaching on this. The galactomannan is actually named after Aspergillus. It was designed for Aspergillus, but it can cross-react with many other fungi, molds, and dimorphics, but not yeast. The beta-D-glucan, it can detect many, but not all fungal organisms. So there are invasive fungal organisms that are not detected by these tests. And so being cognizant of that list, and if you want that list, I think we did a tweet on this. The point is that, Ron, maybe you can, I'm having a little forgetfulness.
He means he crushed it and had a really cool tutorial that I will find and post in the chat.
Thanks. Thank you so much. And so, Robbie, really for me right here is just like, I don't think you can't really use the BMP. Like that doesn't do anything for me. It seems like he's getting dialysis. Like the creatinine means nothing with him being on dialysis. I feel like we haven't really made progress into like what's driving this. And I think that MRI is going to be helpful. But is there any other tests or studies that you can think of, like blood tests that we should be sending at this juncture?
Yeah, Prof. Rez, I'll just kind of summarize where I'm at. I'm really informed by how you're analyzing this, which is like, seems to be a complicated problem because his chief complaint is so interesting and intriguing. He has a rich medical history, which opens the door to many things. And I think understanding this problem will be best informed by figuring out if it's image positive or image negative. And call me silly, but that's all that I'm holding on to right now. I can't really make progress without seeing if he has what his imaging is. And that may be because of how my mind solves this problem. I think that the floodgates might open in terms of our clinical reasoning, depending on which problem representation we go. If we see his MRI with and without contrast is normal, we might then have to go back and get as much juice out of the labs or as much juice out of the medical history. If we get an MRI that has multifocal ring enhancing lesions, we might go a completely different way. So I'm just in a space where I'm kind of getting writer's block. I can't like think more, say more without like knowing what that data point is. So if that's the diagnostic test, I'm in trouble, but hopefully we get that before we have more information. Zach, tell us more, please.
Yeah, so I will. The next thing was an MRI brain. You got an MRI brain with and without contrast that showed a 2-centimeter enhancing left basal ganglia lesion with mild vasogenic edema and a slight midline shift. And he did not have any prior neuroimaging for comparison. I'm also going to give you an additional imaging test we got. It was a CT chest without contrast that Still showed a small peripheral right middle lobe opacity with some architectural changes, but overall significantly improved from the prior CT chest. And I'll pause there.
Oh, sorry, I was taking a second to think about this. Why I was thinking was I was asking myself, do we collapse this problem into the brain lesion and say we have to explain that, or is what Reza talked about, the cerebellum and the heel of the shin, and I was trying to remember what other symptoms person had, not to make the mistake to just call this a brain mass full stop. And I think the midline shift might account for the otherwise non-specific NOS things, but let's keep track if that assumption is wrong. But I think my mind is inclined to say that his chief concern maps on with 100% fidelity to this brain mass, but it might be wrong. That's the mistake we could regret later. And so this case then becomes about having a systemic approach to analyzing a patient with brain mass. It's important to realize that most of the time this turns into an equation about, does this person have an infection in their brain or cancer in their brain? There are some autoimmune diseases that cause brain masses, with sarcoid, unfortunately for the patient, being also on that list. But as is true for most systemic inflammation, we begin our conversation by thinking about infections and cancers. The first approach is to try to understand the problem best by saying, is this an infectious or malignant process restricted to the brain? Or is this a systemic disease with infiltration of the brain from the body? And that's an ongoing question. Is the ongoing opacity in the lung the source or connected to the brain mass? And at cursory glance, that connection is very evident. Nocardia has a strong propensity to do what has happened to the patient. The hole in that hypothesis is, can it do that on treatment for nocardia? Which makes another question. Was this person appropriately treated for nocardia? And the answer to that is, I don't know. I have a vague recollection of most patients with nocardia being on multiple therapies, Bactrim and others in the initial phases of treatment, followed by consolidation into Bactrim. That knowledge comes from 7 years ago when I was a resident with a patient on ID service. So it's faded in its confidence, but still small enough to remind me of that possibility and to look it up in real life. So that's where I'm at in terms of big picture, Prof. Rez, is how do we answer the question, is this a systemic disease with brain manifestation or is it not? Is the lung abscess related? Is nocardia still at play despite maybe partial treatment? And then finally, have we assessed his skin very closely to make sure the skin is not the source like melanoma? And should we consider imaging his belly or getting a PET scan to better frame this problem correctly, either as an isolated brain disease or as a systemic disease with brain involvement? That's the kind of tension I'm struggling with. I'm curious where your brain is at.
No, I love that so much, because even though it's an isolated lesion, you can't completely exclude the possibility of metastatic disease. In fact, we have a patient on service right now with renal cell carcinoma whose tyrosine kinase inhibitor was stopped 2 months prior, and he presents with a fall and ended up having a single brain lesion that was recurrence, unfortunately, of metastatic renal cell carcinoma. But I think the CT scan being negative for findings in the chest, it's just pushing me more towards like approaching this as an isolated brain mass.
Yeah.
And despite the nocardia being negative in the blood culture, I really do think the next step is asking, was it appropriately treated? Because I think, Robbie, we actually had a VMR where it was like an organism that was treated, but it wasn't on adequate antimicrobial therapy. This is a patient I would actually consider Carius testing in. Carius is a DNA freeze from the cells. It's exquisitely sensitive at picking up viruses that have DNA makeup, bacteria, fungi, everything. It's so sensitive. It's expensive. That's the main drawback, and it takes a few days to result. The other thing you could consider doing for advanced microbiology diagnostic testing is a biofire test off the serum with organisms in mind. I think, Zach, what I would do in this patient is just see, like, was he on the appropriate treatment for the nocardia? I'd be open to the possibility that it may represent something else because this is such a vulnerable patient. And I think ultimately the PET CT of the head won't be helpful because the brain is so metabolic. We actually did a PET CT in our patient, Robbie, and they couldn't even see the lesion from the RCC. It was only MRI with gadolinium that actually showed that lesion because the brain is so metabolically active. So the question becomes here, does he need an LP with the hope that something on a biofire from the CSF identifies an infectious organism? But then there's another more practical question, Robbie. This guy has vasogenic edema with a midline shift. Does he need to be on dexamethasone? This is a patient you would get neurosurgery involved. There is no indication for anti-epileptics. I think data has shown their utility is not great unless the patient has like transient loss of consciousness with a brain lesion. So you would be wondering, and honestly, in this patient, I would probably give dexamethasone with the vasogenic edema because you can get into, like, he's having obvious symptoms, he's having a midline shift, but I would be consulting neurosurgery. So really the questions I'm asking from a practical lens and from like being the attending a record, if this was presented to me in the morning, I would say get neurosurgery involved. He probably needs to be on dexamethasone. Was the nocardia adequately treated? We should probably get ID on board. Does he need a carious testing? Do we need to do an LP and go from there? And if the nocardia wasn't adequate, I don't know if that would still be comfortable saying, hey, this is all just nocardia that wasn't treated appropriately, unless the ID doctors guided, like the transplant ID doctors guided me differently. But I'm heading towards getting an LP and doing further microbiologic studies. But I think we got to make sure it's safe to do that LP. And I think we got to give some steroids to decrease the swelling because he's obviously symptomatic from that vasogenic edema and where the brain lesion is.
Yeah,
Thoughts on
great.
that, RG? Yeah.
Superb, man. Absolutely superb. I agree with you. Yeah. I think,
Yeah. Oh, sorry, go ahead.
No, Dad. I was just going to transition to you, my friend. That's all.
Great. Yeah, great discussion. You guys are wrestling with some of the same questions that we had when we were seeing this patient and he was on a transplant service. So, yeah, we ideally Bactrim monotherapy would not have been the appropriate initial treatment for this patient. And so we were wrestling with whether the clearance of the bloodstream infection, the improving pneumonia, were signs of the nocardia infection being appropriately treated, but we weren't entirely sure since he had this presumed new brain lesion. We did give him dexamethasone. We did consult neurosurgery for their input. And they said the lesion was in too precarious of a location to go for biopsy. We discussed the possibility of doing a lumbar puncture, but with the degree of midline shift and edema that was there, the neurology and neurosurgery teams were a little bit hesitant to pursue that, at least at this point in the patient's care. So transplant ID was heavily involved, and they had a high suspicion that this was still CNS nocardia. And since we were unable to get tissue diagnosis, they wanted to just empirically treat for CNS nocardia. And so the patient was started on meropenem and linezolid and continued on Bactrim for treatment of presumed CNS nocardia. He remained in the hospital while all this was going on to see how his symptoms would evolve. And so he, about 10 days into his hospital course, his symptoms were relatively unchanged. And so we repeated a brain MRI with and without contrast at that point. And he had the same left basal ganglia lesion that had increased in size and now had some associated rim enhancement. And he had 2 new lesions in his right parietal lobe. And overall, the degree of vasogenic edema and midline shift were stable. And I'll pause there. The next aliquot has 1 additional diagnostic test, and then we'll have the final diagnosis.
Zach, this is super helpful. Can I ask, how long did you keep him on the dexamethasone? Is he still on it? At this point, is he still on the dexamethasone?
Yeah, he was on it for pretty much that entire course.
Yeah. I think that makes a lot of sense. And yeah, appreciate the caution with the LP and the consequence of brain herniation. You definitely don't want to cause harm. So whenever you have a case like this, you can use your treatment as your diagnostic test. And the truth is, I love, like, this is where you have your experts on board, where if I were the attending of record, I would follow their guidance and I would agree with this. Like, just empirically treat, see what happens. And if you think about it, like if it were nocardia in the brain, you have the blood-brain barrier. And so you might not get as much bacteria. So it's like a good hypothesis, and that could be an explanation. But now we started treatment. So then the question becomes, what do you expect to happen when you initiate the appropriate treatment for nocardia? I don't know the exact answer for that, but I can tell you I don't expect it to get worse. Maybe it doesn't get better quickly, but you shouldn't have multiple lesions popping up, assuming you have the right dose of the antibiotic. So now I think we actually have to step back and say, what is causing multifocal lesions in the brain? And really, it's the MRI can be helpful when you, and this is not something that an internist would do, but if you look at the diffusion restriction, and the radiologist may be able to tell you if they favor an infectious process or a malignant process based on the diffusion restriction. Now, I don't even remember which one is which, but I just know that there is a difference there. So now we're dealing with, are we missing an infection, or is this a cancer? And if cancer, which cancer? I think something that I would have considered even before empiric treatment is lymphoma. Lymphoma in someone who's immunocompromised is absolutely a possibility. And I would have sent an LDH off that initial lab just in case it came back extremely elevated. And whenever you have brain lesions, there's certain infections like lymphoma, toxo, crypto, that are like the common culprits of brain lesions. So if I would send an LDH, I would now further strengthen the hypothesis of a possible cancer because of the immunosuppressed status. I would consider a PET CT in this patient, knowing that maybe the brain won't be helpful, but the rest of the body, if something lights up and shows FDG avidity, and if you ask what tumors have a tropism for the brain beyond lymphoma, what solid tumors, we have a mnemonic of MRCT. And the thing with mnemonics, it's good if you can remember what they stand for. I believe the M stands for melanoma, the R stands for renal cell carcinoma, the T is for thyroid, and I think the C is for choriocarcinoma. But you guys can correct me in the chat if I'm mistaken. But those are the cancers that were most solid cancers. So either you're dealing with, but one last caveat that Aaron taught me, lung cancer is the most common cancer. And lung cancer, because it's the most common, even though it doesn't have as much of a tropism for the brain, it ends up being the most common cancer that actually spreads to the brain. So I would get a PET CT scan. I would definitely send a Carius test in this patient. I think it can give you an answer. I really do. And then I would step back and say, what organisms are not being treated with the antimicrobial regimen this patient is on? And those would include mycobacterial organisms. And this guy has a history of latent TB or something like that. So could this be tuberculosis that's now showing itself? Absolutely, it can be tuberculosis that's now showing itself. And the last thing you want to use, and I'll love to hear Robbie's thoughts on this. We literally have an MRI from like a week prior. So we can ask the question, what can grow so quickly that you had a negative image and now you have a positive image? So it's not like a slow growing brain tumor. It's not a slow growing infection, whatever it is. This thing is rapid and it's like showing its phase. So non-nocardia, atypical infections like mycobacteria, fungal infections, or is this metastatic solid cancer, or is there a lymphoma that's lingering in the brain? How to make progress, a PET CT, a Carius test, and yeah. But Robbie, what's your take on this, my friend?
No, I think that's absolutely a great analysis, and the only things I can see help us make progress. I completely agree. I think if it is safe to do an LP, which is not, sometimes if seeing if there's a lymphocytic response or a neutrophilic response can help you make an educated guess. It's also another fluid that you can send infectious testing for, but I know you already thought about the pros and cons of LPing this person. But as you start to think about lack of diagnostic clarity going forward, you may take more risks than you otherwise would. So that may be something you guys thought about. All right, Mike, to you, Zach.
All right, awesome discussion. I'm gonna have to ask if we had Carious testing available because we did not even talk about that. And I'm curious if it was maybe in hindsight something that could have been done.
No, it's probably because it wasn't indicated, Zach. I tend to make recommendations on the VMR. Like I love steroids. I almost say give methyl. Robbie knows this. 2 out of 3 now, Robbie. I'm right.
It is in fact more than 50%.
The other time the patient had endocarditis when I said give a gram of methylpride.
So yeah, the patient did have an LDH check that was elevated. He did have a PET CT that just showed uptake in the 3 areas of the brain that were shown on MRI. We rediscussed the case with neurosurgery, and they felt a little bit more comfortable going after one of the right parietal lobe lesions. And so the patient did ultimately get a brain biopsy that showed EBV positive large B-cell lymphoma. And so his final diagnosis was like post-transplant lymphoproliferative disorder involving the CNS. And so he actually remained inpatient and was started on rituximab, switched to prednisone, and got whole brain radiation therapy with actually pretty good improvement in his mentation, but not quite returned to baseline. And so he was discharged with outpatient oncology follow-up. And at least from what I can see from his outpatient records, looks like he's doing reasonably well, not quite back to baseline, but had some meaningful improvement in his neurodeficits that he presented with.
Oh, well, I mean, what an incredible case. I think, you know, I'm trying to think of how this could have been so much worse for the patient. Because if he had showed up with simultaneous lung mass, because the nocardia was separated out by 1 month. Imagine if he held out a little bit on the nocardia, he would have shown up. We would have found the nocardia lung abscess. We would have imaged the brain and seen a brain mass, and we would have definitely assumed that the brain mass is the result of nocardia if they had been coexistent. And I imagine the time to diagnosis of primary PTLD related CNS lymphoma would have been so much longer. So it sucks for the patient that he had to go through 2 different healthcare experiences, but I can see if they were combined, it would have been so much more arduous and complicated for him. I think the ultimate lesson that I take away from this case is when patients are immunosuppressed, they can have as many diagnoses as they please, and not only diagnoses as they please, but also diagnoses in different categories. This person has a really bad infection from immunosuppression and a really bad cancer from immunosuppression in the same patient 1 month apart. And it just goes to show you how ultimately the best test for the patient is how is the patient doing? And if the patient's not doing better, all diagnostic things go out the window. And you have to have a very, very, very low diagnostic threshold to look for things as Prof. Rez ultimately emphasized. Yeah, really, really humbling case. A lot of things to reflect on. I'm curious, what do you think how are you different, Prof. Rez, from having thought about this case now?
Well, first of all, Zach, I want to thank you for bringing this case to VMR. And I think the way you broke up the aliquots lended itself to a great discussion and a lot of teaching points. I'll just make a quick comment, and then I would love to hear, Zach, your overall learning from this case before Amo takes us through with her teaching, which she always comes with a lot of fire and enthusiasm. So I always love listening to her. I think my main takeaway, Robbie, when I was creating that framework for like a transplant patient, and I've seen, like, we've done so many CPSs that is post-transplant lymphoproliferative disorder. I'm curious to know, like, for you, was there a reason you didn't consider that hypothesis earlier, or was it lurking in the back of your mind? I'll say for me is like the patient didn't come with a lot of lymphadenopathy, but like recognizing that that diagnosis exists. And I think going forward, I would put it in my framework. You know, we talked about graft versus host with post-transplant lymphoproliferative disorder, the myriad of ways, just so my mind is ready to like, you know, send that LDH early on, as opposed to wait longer in the discussion. But I was curious for you, Robbie, why, or if it did percolate, or if this just doesn't match your illness script.
Yeah, no, Professor, I think that ultimately my mind was still in a place of until the very last aliquot trying to understand the problem. And it only is really until the last aliquot that we had a good problem representation of progressive brain lesions despite appropriate antibiotic for nocardia. So I really don't think that we had a lot of cognitive bandwidth to analyze the whole range of possibilities until the very last minute. And that's just authentic to what I'm trying to do as authentically in VMR in real life is only start to solve it if you know what it is. And I think that final aliquot of, oh, progressive brain lesions despite antibiotics was such a powerful pivot that it took neurosurgery to say, oh, we're not going to biopsy to what other option do we have? And so I think at that point, it's a very, very good time to review your own script for PTLD and to reflect on it. But I think beforehand, we probably would have thought of it in real life, but we probably know that it belongs at the end of the train tracks, not anywhere near where we are right now, you know, because there's just no other way to prove its existence apart from PET CT, as you said, and getting tissue peripherally. But if there's no tissue peripherally, so that's why I think it was waiting for the problem to declare itself was my take.
Thank you, Robbie.
Yeah, for sure. Zach, what's yours though? Most importantly, man, how did you what were you learning as this case was evolving, and what was your takeaway now?
Yeah. I think the case does a really good job of reinforcing like Hickham's dictum that patients can have as many diagnoses as they want. And I think that's like especially true in patients who are immune suppressed and prone to like multiple different disease processes going on at once. Some of the other learning that I got from it is that if you diagnose somebody with nocardia, you should get brain imaging at the time of diagnosis just to make sure there's no CNS disease. And you should always send the whatever specimen you get, whether it's a bronch specimen or a blood culture specimen, for susceptibilities, because they do vary quite a bit between different species of nocardia, and it's hard to tailor an appropriate antibiotic regimen unless you know the susceptibilities. And then someone in the teaching points or in the chat mentioned that you can have EBV positive PTLD with a negative serum EBV DNA. And that was a good learning point for me, that the negative serum testing did not rule out PTLD in this patient.
Can I ask Zach just a quick clarifying question on that? Did you, in your learning, learn that EBV in the PCR is a good EBV PCR negativity does not rule out EBV positive PTLD in general, or does it not rule out EBV positive PTLD in the brain owing to the blood-brain barrier?
Oh, that's a good question. I'm not entirely sure.
I'm intrigued. I don't know the answer either. I don't know. Do you know, Prof. Rez? Yeah, it's a good one to look up for sure. Yeah, it's amazing how lymphomas in the brain in general are so hard to access. Like you think about what tools do you have to diagnose primary CNS lymphoma or HIV-related CNS lymphoma? Like nothing, and the EBV and the CSF can help you, but not in the blood. So I'm gonna dive deep, and I will report back on that
And
question.
it's also curious, Robbie, that like the patient didn't get better with the DEX. Like I wouldn't, because DEX is like part of your treatment for that's interesting. Like, so I have to not use that as like it's unlikely to be lymphoma because it's not shrinking and it's worsening.
Prof. Zach is presenting 2 other cases next week, and this is his beginning case. So I think we're in for a treat. Zach, this is so cool. Thank you for such an educational journey. And I really just want to emphasize what Prof. said. You really set us up for a very rich conversation. And ultimately, I will say the CPS clue that it wasn't nocardia, as you chose to mention it in aliquot number 1. So for all of you CPS enthusiasts, keep that in mind. But anyway, Anmol, I'll pass the mic to you for the teaching points.
It was an amazing case and amazing discussion. And thank you, Prof. Rez. Your compliment made my day. And a wonderful discussion in the chat as well. So starting with the complaint, the patient came up with the complaint of AMS. And when we think about altered mental status, we say that tempo is the key. We think if the primary problem lies in the brain, or is it a systemic disease which is affecting the brain? So then if we evaluate AMS, we think about mismnemonic, thinking about metabolic, infectious, structural, or neurologic, and toxic causes. So to evaluate all these 4 buckets, we think of reviewing the med list, the checking for the complete metabolic profile and the ammonia levels. Now this patient had an interesting thing that the patient was status post-transplant. So whenever we have a transplant history, then we think of 2 things, over-suppression or under-suppression, because the patient is on immunosuppressive medications. If the patient is being over-suppressed, then it could lead to the malignancy or infections. And if the patient is in under-suppression, it could basically lead to the graft rejection. So we were thinking about, is it direct toxicity from the immunosuppressive medicines? For example, tacrolimus, which the patient was having, it can cause TMA or PRES, or it was a disease consequent to the immunosuppression, as we talked about the malignancy or infection. Then another thing, there could be directly involvement of the transplant organ or the graft versus host disease, which also shows up on the skin and GIT as well. And then this patient was basically end-stage renal disease and on dialysis, which increases the risk of thiamine deficiency as well, which can also present neurologically. And then we saw the history of nocardia. So basically, nocardia is a soil-borne organism and has tendency to affect the skin, lungs, and brain, which can cause brain abscess. And then we also saw the presence of sarcoidosis, which is basically a diagnosis of exclusion. And it has granulomas affecting the lungs with other extrapulmonary symptoms as well. And sarcoidosis also increases the risk of lymphoma and cryptococcal disease. So till now, we were having many differentials for the possible AMS. And then we saw on examination presence of multiple focal neurologic symptoms. Therefore, we decided that MRI brain with and without contrast and looking at the systemic fingerprints would help in this case. And also we learned that in an immunosuppressed patient, serologic tests are of little value. Like galactomannan can cross-react with other fungi or molds, and beta-D-glucan isn't able to detect many fungi, for example, Cryptococcus plastomyces. And then the patient also had tremor, which we thought could be secondary to the tacrolimus neurotoxicity, or it could be a cerebellar tremor as well. Then we saw in the imaging that the patient had brain mass. So whenever we think of a brain mass, we think if it is infection or is it a cancer? And we can make some idea based on the diffusion restriction seen on the imaging. One question is infection or cancer. Second question is if it is restricted to brain or is it systemic? And this patient had a lung opacity as well. So we thought if the lung opacity was related to that, because we need to see lungs, liver, skin, and spine whenever we have a brain mass to rule out all the systemic fingerprints. And then we also thought if the nocardia in this patient was completely treated, because if not treated, then also it can present like this. So basically, it was we started the treatment for nocardia as well again, but it was basically a progressive brain lesion despite antibiotic treatment to nocardia. And so the next steps we thought were maybe imaging the abdomen, PET CT, LP, or LDH if we considered lymphoma in this case. And also we thought about the tumors which can metastasize to the brain, like with the mnemonic of MRCT, melanoma, RCC, choriocarcinoma, and thyroid. And the presence of vasogenic edema with midline shift, we considered giving dexamethasone in this case, and we consult neurosurgery. So everything was done to, therefore, the brain biopsy was done, which showed EBV positive large B-cell lymphoma. Hence, the patient was actually diagnosed with a post-transplant complication only, leading to malignancy affecting the CNS. So it was an amazing case. Thank you so much for the discussion, and thank you so much.
So did I lie, anyone? Isn't that fire in Almo's voice and her teaching? Thank you so much, Almo. I love when you teach.
Absolutely superb. I couldn't agree more. Have a wonderful day. Thank you again, Zach. Thank you, Prof. Rez. Thank you, Ambish, for scribing. Thank you, Shamer, for always co-helping with the scribing discreetly, but not so discreetly anymore. We caught you in the middle of action. And of course, thank you, Anmol, for your epic teaching points. We'll see you all later.